Depending on where you're joining us from, good morning, good afternoon, and good evening. I'm Neeti Daftari. I'm Program Manager at Transforming Faces here on behalf of the Circle of Cleft Professionals. I'm very excited to welcome you to our 28th COCP webinar titled The Cleft Collective Cohort Studies, Building a Research Resource for the International Community. Once again, we will be having simultaneous interpretation in Spanish, for which we have Felipe and Eva joining us on this webinar from Chile. At the bottom of your screen, you will see an interpretation button. If you click on that button and select Spanish, you will be able to follow the rest of this webinar in Spanish. So please go ahead and select the webinar, the language of your choice. Here are some tips on how you can make the most of this webinar experience. If your bandwidth allows, please keep your video on. Feel free to type in your name and let us know who you are and where you're from. While the presentation is on, and if you're not addressing the group, we request you to keep yourself muted. But at any point during the presentation or discussion, feel free to type in your questions and comments or to use the reactions button at the bottom of your screen. Once the presentation is done, we'll open for discussion where you can post your questions either via chat or on video. The agenda is the same as always. We will begin this 60-minute webinar with a quick COCP update followed by a panel presentation. Joining us today is a Cleft Collective team, Kerry, Yvonne, and Matt from the University of Bristol in the UK, who will share with us on how to use a large cleft lip and palate data set, including biological samples and clinical data, and will show us how we can get involved in this important work. Once the presentation is done, we'll open for discussion, which will last for the remaining half hour or so after the 25-minute presentation. We have three core objectives at the COCP. We focus on comprehensive cleft care in low and middle income countries. Our aim is to facilitate networking and collaboration to communicate the impact and learning that's happening within cleft care and to support the growth of local teams in implementing comprehensive care. Within the COCP, we are now over 500 members strong from 70 different countries around the world. As you can see here on the right, the COCP represents professionals from a whole range of different specialties, including nutritionists, orthodontists, social workers, nurses, and so on. You can also see here that the majority, that is over half of our members, are surgeons and speech therapists. These are the 70 different countries around the world that all of you, our members, come from. The ones in green being the countries which have the largest membership. Finally, the COCP is made possible thanks to these 11 international charity organizations, all of who believe in comprehensive cleft care in low and middle income countries. And now I invite Hugh to introduce himself and our speakers for the day.
Thanks, Neeti. Well, hello, everybody. Thank you to everyone who's been writing quick notes of welcome on the chat. Please be encouraged to do so, just your name and where you're from, so we can get a sense of who's in the room. But it's a great turnout this morning, and I'm not surprised. I think the topic of research, especially LMIC-rooted research, is top of mind for many of us, especially as we're thinking even today about how we respond to COVID. And just to pause for a second, just thinking about some of our colleagues who are not with us this morning. We're thinking of especially those in Ethiopia. I see Mand here from Myanmar as well, but definitely in our thoughts. We're getting a quick update from Siraj earlier, even around some natural disasters. I mean, this is an interesting time, a difficult time to be a cleft professional. And yet, I think that the idea of research and studying what we're learning about how to produce and how to deliver comprehensive cleft care is so important. And one of the places around the world is really driving this forward, I think, is the Cleft Collective. So I've been so delighted. I've been following on Twitter for quite some time what they've been up to and some of their studies. I'm delighted to have Kerry Humphries, Yvonne Wren, and Matt Fell with us today. And they really understand this idea of how important research is in driving the agenda for comprehensive cleft care forward. They're going to be joining us today to talk a little bit more about what they've been studying and how they've been approaching this, and potentially, as we saw, how this can be a resource for the rest of us around the world, not just based in the UK. So Kerry is a research operations manager for the Cleft Collective. Yvonne is the chief investigator for the Cleft Collective, and Matt Fell is a UK trainee in plastic surgery. And we're delighted to hear from them today. So without further ado, I'll pass it over. I think Yvonne's going to lead us through, and then be ready along the way. Feel free to type in some questions or comments, and then we'll have as usual, a chance for really to think about how does this apply to our own context and what questions do you have for these presenters today at the end.
Great. Thanks, Hugh. That's fantastic. Now, the first thing that I need to do is just to share my screen, which is what I need to do first. So just give me a few minutes while I do that. It all worked incredibly smoothly before we tried to share. And you know, I
could vouch for this. It worked very well. It was flawless the second time.
The minute you're going to do it, it's not going to work so well. But I'm nearly there. There's just a few extra things I needed to do to make sure you can see properly. Now, hopefully, you can see our opening slide. Is that right? I can't see any of you, so you're going to have to say something out loud to me.
Yes, we can see it.
Brilliant. Yeah. Thanks, Niti. So what I'm going to do, I'm going to hand straight over to Kerry, who's going to give us a lot of detail about the Cleft Collective. Then I will talk a little bit about how you might want to get involved. And then we'll hand over to Matt, who's been involved in using the data so he can share his story. So over to Kerry.
Thanks, Yvonne. So firstly, thank you very much for inviting us here to talk today about the Cleft Collective. We really appreciate it. We've been going for some years now, and we think now is a really good time for cleft professionals to get involved with the study, because we have the data here ready and waiting for you. And I will talk a bit about that now. So if we go to the first slide, the background. So the Cleft Collective is a longitudinal cohort study collecting biological samples, parent questionnaires, medical records, genotype data to investigate the biological, environmental causes and best treatments of cleft. So we found that parents often ask three key questions when their child got diagnosed with a cleft, and that's what we've built into the aims of the study. So what caused the cleft? What are the best treatments? And will my child be okay? So within the study, we have various strands. So we recruit antenatally, postnatally, and also when the child is 5 years old and they attend their audit clinics. So I think it's really important to stress at this point that this is a resource which is available for researchers and clinicians worldwide. There's no other cleft study in the world like it that has the breadth and the depth of the data that we hold. And I'll go on to talk about that data now. So we recruit from all of the 16 NHS cleft surgical sites in the UK. So that's in England, Wales, Scotland, and Northern Ireland. And so just to give you an idea of what we collect, so first of all, I mentioned biological samples. So if the parents are recruited antenatally, it means we can collect cord blood. If they're recruited postnatally, it means we can collect lip and or palate tissue from the baby at the time of the operation, also their blood. And we collect saliva from the parents, whether they were recruited antenatally or postnatally as well. And if there are any siblings, we do collect saliva from siblings as well. If they're in the 5-year-old cohort, then we collect saliva from the whole of the family. We also collect questionnaire data. So this is from the mother and the mother's partner. So that can be the biological father, but we also have same-sex couples in the study as well. And the questionnaires start at baseline. So soon as the family are recruited into study, they'll fill in a questionnaire. And then at these following time points as well. And then at 8 years, we do send the child their own questionnaire to complete as well. We're also in the process of putting together a 12-year questionnaire. So we hope to continue for as long as possible, as now especially a crucial time as a child as they're entering adolescence. So in the questionnaires, you've got main demographic questions. We have standardized psychology measures as well. We ask about lifestyle, medical background, so lots and lots of different questions. We also ask the child's surgeon to complete information about the child's surgery, and that includes timing and technique. And also during COVID last year, we were able to put together an online questionnaire that we sent out to our parents as asking about how it affected their child's education, the child's well-being, and also investigated further how it was affecting their cleft treatment and whether it was delayed. During the consenting process and on the consent form, we also ask parents if they would mind if we link to the medical records. So that's held by the Cleft team, but also linking to records held by their GP as well. We also ask to link to the child's education records for when the child starts full-time schooling, compulsory schooling. And we also ask if we can link to their records held by the Crane database as well. For those of you that haven't heard about Crane, it's information about all children born with cleft lip or palate in England, Wales and Northern Ireland, and soon to be Scotland. This data collection is optional. So if parents would prefer not to consent to this, that's fine, they can still be in the study, but we explained that by consenting to this, it gives us a lot more information about the cleft treatment. So as I've just explained, we hold a lot of data, so biological, genetic. Currently, all our biological samples are in the process of being genotyped, and that is due to be finished anytime now. Developmental data, environmental data, clinical, linkage, and functional data as well. So you name it, I think we've got it, which is great for us that we can house this resource and offer it up to clinicians and researchers to use. So in terms of where we are now, we have over 9,500 participants in the study, and that's from nearly 3,500 families. And there you can see the breakdown of whether they're antenatal families, whether they were recruited postnatally, or whether they were recruited during the child's 5-year audit clinic. And in terms of the data and the samples that we now hold, again, we've got some numbers there as to how many samples we have in terms of blood, tissue, surgical form, questionnaires, saliva samples, and cord blood. And again, you know, we are really proud of our resource and how many samples that we've been able to collect over the last few years since the study started. And I'll go back to what I said earlier, that there'll be no other study that holds this amount of data, this number of samples that we currently hold, and we're still recruiting. On top of those we've mentioned there, we also have a speech and language sub-study. So those that are recruited into the main study can be recruited into the speech and language study if they have a cleft palate. And as you can see there, we collect at 30, when the child's 13 months old, we collect a Lena recording, which actually a little recording device that the child wears, and then it records the interactions from the child and their carer, and babbling sounds from the child as well. And 18-24 months, we have speech and language therapist assessments, and again at 36 months as well. And then throughout that time, we're also accessing hearing records as well. So that's a very brief overview on all the information, the data we hold, what we collect. But actually, what's really important today is that, you know, the message we want to get across is that this data is available for you to use. We're not collecting it just for us. We do use the data, but we are encouraging cleft clinicians, academics out there to use this data in order to carry out their own research. It's a really, really straightforward process. We make it as simple as possible for you, but also part of the role that we have is to assist you in accessing that data and to make it as straightforward process as possible. So you can find out all the information about accessing the resource on our website. And then on the website, you will also find our data dictionary. So this is a document. I think, Yvonne, if you just bring up the next slide, thank you. So this is an example of what the data dictionary will look like. So it'll have the variable name and the label, and then it will give you some information about that as well. So we've done that for all the information that we hold. So you can have a look through there and have a really good idea of all the information that we hold. And that includes all the questions that we ask in our questionnaires as well. So that will give you a bit more information about what we collect when parents complete and children complete our questionnaires. So that can be found on our website, and also on there you will find our research proposal form. And the next slide will give you an idea of what that looks like. So again, we try and make it as really simple as possible. We don't ask for too much information there. And again, we are here to assist with the completion of that proposal form. So if you have an idea, feel free to get in touch with us first. You can email us, and all our information is on the website. We can discuss potential research ideas with you before you fill in a proposal form. Have a look at the data dictionary. We can give you an idea of how many samples we hold to answer the specific question that you may have. And then you fill in the proposal form. This will go to our project management group to sign off. And then once we've done that, you've signed the confidentiality forms, we would send you the data. So it's really straightforward. And the next slide will give you an idea of research proposals that we've had already. So we are really pleased to say that we've had 41 research proposals received so far to use the data set. So lots of really brilliant research going on at the moment. And I've just picked out 4 here just to give you an idea of the breadth of the research going on. So we've got genetics, we've got speech and language, we've got something looking at psychology, and we've got surgical questions being answered as well. So lots and lots of exciting research taking place at the moment, but because we collect so much information, there is definitely room for lots and lots more. So I am going to pass over to Yvonne now, who is going to give you a bit more detail about getting started and involved in research.
Okay, thanks, Kerry. That's all really helpful. So Kerry's given you a lot of detail and information there about the study as a whole, and there's lots that you can look up on our website. There's lots more information there. In terms of getting involved, I think there are 2 main ways. One is to use the data yourself, and the other is to attempt to replicate something, replicate the study. Now, just talking first of all about using the data, as Kerry said, we have set this study up for the international research and clinical academic community. This is for all of us to use to address questions relating to the causes and the treatment and outcomes for children born with cleft lip and palate. So we really want you to use it. The key thing to think about is what is your research question or clinical queries, having some thought about refining that, so you know exactly what you're trying to address, and then you can have a conversation with us. You can look and see what data is on our website, but also have a conversation with us so that we can help shape that question so that it fits with the data that we have. So there's lots and lots that we can address that will have an impact on clinical care moving forward. So the question is looking at whether the data that we've got can help you answer that clinical query, and do talk to us about that. Now, the other thing is that people have asked us about replicating the study where you are, and there are advantages to doing that. I've noticed some of the countries that you're all coming from, and it's such a range around the world, and I completely understand that you would want to collect local data. That means you can look at how some of the questions you might ask of the Cleft Collective generally, how it might relate to your local situation. So it totally makes sense to do that. However, it is quite a big undertaking, and I'm going to talk us through that in a minute. And I think the important thing to do is to remember that the more we collect the same data, the more that we can combine the data that we collect, the larger the sample we have, the more power we have to address research questions that will have a real impact for us in our clinical care. So just bear that in mind, because that's a theme that's going to run through my next few slides. So just to tell you about a few others who have taken this route, John Thompson at the University of Auckland in New Zealand He's very much done something very similar to what we've done in the Cleft Collective. New Zealand's got a much smaller population. So by collecting the same data as us, it means that we can combine it together, and he can look at data relating specifically to New Zealand, but he can also see how that data compares with data in the UK. We've also partnered with Elizabeth Leslie in Atlanta in the USA. Her study is quite different, but she's using our parent questionnaires, our baseline questionnaires, so when we first recruit the families. So again, we can look at how we can combine that data, because Elizabeth is also collecting biological samples, so there's the potential to combine the genotype data as well. We're also in discussions, as we talked a little bit earlier, with teams in India and also Kuwait and Malaysia. So there's a lot of people we've been talking to about setting up similar studies. But as I have said, this is a big undertaking, so not something to be undertaken lightly. In terms of how we set it up in the UK, one of the really important things for us, which I know is different for a lot of other countries, in the UK, we have centralized service provision. So what that means is, as Kerry said, there are 16 sites around the UK where cleft services are provided, specialist cleft services are provided. And that's where the surgery takes place as well. So we were able to work with those 16 sites who already work together very closely. So this meant we were starting something, starting to collect data with a group of professionals and clinicians who are already working very closely together. So the concept of collecting the same data is something that they already do. So just bear that in mind with your particular country, your region. Do you have a centralized service where you could agree with others what you might collect? Or is this something which needs to start really quite small with just your own service and get into a pattern of collecting data that you could then share with other services around your country to see how it could be done on a bigger scale? We also have a lot of support in the UK. So all of the data that we collect is supported by an ethics approval documentation. So we know that we're collecting data that has been approved, that it's ethically sound. We also have support from the National Health Service itself to collect these data. It can make it at times quite a bureaucratic process for us. But on the plus side, we know that what we're doing is robust from a research point of view. We know that it's ethical from our patient's point of view and from the clinician's point of view. So again, it's about looking what support you have within your region to do something similar and to ensure that it is being collected in a robust and ethical manner. And we have lots of documentation about how we have achieved that, and we are happy to share a lot of that. So again, do get in touch. So then it comes down to making decisions about, first of all, recruitment. Who are you going to recruit? When are you going to recruit them, and how? Now, in the UK, we decided that we were going to recruit any child born, or at least invite to participate, any child who is born with a cleft of any type. And because of the age of the children, we are recruiting their parents who are giving consent on behalf of their children, as well as consent for themselves. And we recruit those families when they turn up for an appointment at their regional cleft service, usually the appointment, the pre-surgical appointment, so just pre-lip repair or pre-palate repair. Or as Kerry said, it might be when they turn up at age 5 for an audit appointment. What happens in the UK is that all children at age 5 come to the cleft centres to have a range of different assessments from the multidisciplinary team, so that we can check progress and we can compare across sites and ensure that we are maintaining a certain standard of outcome across all the sites and over time. So that's another time when we can recruit children. So those are the things to think about. Who are you going to recruit, when and how? Because it needs to be consistent, and you need to have a very clear process or protocol that's written to determine how you're going to do that. Similarly, it needs to be a common process for collection of data. And it's these common processes for recruitment and collection of data, which if you can do something similar to what we've done, then we can potentially combine those data sets. It increases the power of your data, it increases the power of our data, but we're all working together to improve outcomes for children born with cleft lip and palate. So it's a win-win for all of us. So we have forms that surgeons complete following surgery to repair the lip or the cleft. We also have speech and language therapy forms that are used when the children are assessed at age 2 and at age 3. And as I've already referred to, we have an audit clinic at age 5 that's part of the ordinary clinical care, and there's data on outcomes that we'd be able to collect from that service as well. We also have questionnaires, as Kerry mentioned, that are sent out to parents at various times. So we can share these with you so that they could be collected locally. Depending on the country, obviously there will be needs for translation. In fact, there are needs for translation in the UK because we have many languages spoken. But so those are things that we can talk to you about. Storage of data is a really important thing to consider. And in fact, I'm going to add the next bullet point because the plan for analysis. These are not two things to add on at the end once you've started collecting. These are things you need to think about right at the beginning. How are you going to store the data so that it's secure? How are you going to store the data so that it is anonymized? We need to know who our participants are because we need to contact them and send them questionnaires and we send them birthday cards, in fact, and we send them newsletters. So we do know who our participants are, but when we share the data, it's anonymized. So you need to think about how you might manage that. Again, this fits with what's required from an ethical point of view, that we aren't sharing any patient identifiable data and that we're not using patient identifiable data in our research reports. And the importance of planning for analysis is so that you're collecting the right data to carry out the kinds of analysis you want to do. I'm sure you're all familiar with that as a sort of basic premise of carrying out research, but it's always important to add it in there. Okay, so there's quite a lot required, and this isn't to put you off, but this is to give you a sense of what you need to do in order to do something similar. So how we can help, well, I've already said some of this, so we can share our processes, share protocols, share questionnaires and data collection forms. We want to enable you to collect data that can be combined. So wherever we can, we're keen to help. The chances are you will still need to find some funding or support locally to do this. This is not a small undertaking. This requires a lot of time and effort. And we have a strong team. Kerry heads up a team of individuals who are responsible for collating the data, for collecting the data, for liaising with the clinical teams, etc. So don't underestimate what's involved and look to see what support you might be able to get to help with this. But I would come back to asking yourself, do I need to do this? Or can I use the Cleft Collective data instead? Because that's why we've done this. We've done this because we can do it, and we've done it so that we can share. Okay, so have a think about that first. Okay, if you've decided after all that you are still going to go ahead, and we're not saying don't do it, we're just saying think hard about it. So be realistic about what is possible in the environment that you're in. I've said there focus on one area, and I think what I really mean there is start small. Better to start with one thing that you can do really well and then potentially expand it out. So for example, I mean, my clinical background is a speech and language therapist, so I'm going to use a speech example. You might decide that you want to collect data on children's speech at age 3, and you decide, okay, well, I'm going to use the same assessment form that the Cleft Collective use, because then we can see how the data compares from one country to another, as well as potentially combining the data. And you might want to collect data on the surgical intervention. It might just be the timing of the cleft palate repair, for example. And then you can see how the outcomes at age 3 might vary depending on how old the child was when the palate was repaired. So that's what I mean about starting small. And I know Brian Summerlad's on this call today, and Brian's got lots of experience in terms of identifying specific clinical research questions, really refining what that clinical question should be and making sure we collect the right data for that. So define your questions that are driving the research. And then, as I've said, collect the data which can be combined. Now I've put a few logos there and a photo there. This is just to highlight we work with lots of different organizations, and we're working with both Operation Smile and Smile Train. Operation Smile are doing a fantastic family study where they're collecting lots of biological samples and questionnaire data, demographic data on their participants across, I think it's 5 different countries. So LMIC countries, and we've in talks with them about how we might be able to combine some of our data and work collaboratively more moving forward. And we've been in touch with Smile Train as well about the potential for starting something similar in India. So you know, we are absolutely keen to work with different organizations, different countries. And I'm just showing a picture there of Elizabeth Mangold and Kirsten Ludwig in Bonn in Germany. And again, we collaborate with both Elizabeth and Kirsten, who for many years have been collecting biological samples to do genotype analysis to understand the causes of cleft. So again, different ways that we can work together. Okay, I'm going to move on. So what I want to do now is hand over to Matt. Now, Matt, fortunately, is with us today, but we thought he might not be. So Matt very kindly recorded his presentation earlier. So I'm going to just play that now. It's just over 5 minutes long, and then I think we'll have a chance for questions.
Hello, everybody. My name is Matt Fell. I'm a trainee in plastic surgery in the United Kingdom. And I've been using data from the Cleft Collective for the past 3 years. I'm grateful for this opportunity today to describe the ways in which I've been using that data. Yvonne and Kerry have described the vast array of different types of data within the Cleft Collective. But personally, I've had experience of using 3 different types of data: clinical, biological, and questionnaire data. And this has been to answer 2 very different research questions. And I'm going to go through those for you now. The first question that I wanted to ask involved the UK cleft surgery pathways, because I really wanted to understand at what age children were having primary reconstructions for cleft lip or palate in the United Kingdom, and what sort of surgical techniques were being used. I wanted to define a benchmark for current surgical practice in the United Kingdom so that I could compare against different countries around the world. I used clinical data within the Cleft Collective to answer this question, and this was from the Cleft Collective surgical form shown here on your right. This is filled in by members of the surgical team after each operation for children enrolled in the Cleft Collective. And it has the type of data that I needed because it records the age at the repair, the type of surgical technique that was used, and any adjuncts such as steroids or antibiotics during the operation. I used data from 1,782 surgical forms, and these graphs are an example of the analysis that I was able to perform here specifically for primary lip reconstruction. On the left, you can see a histogram, and this shows that lips tended to be reconstructed most commonly at 4 months of age. And on the right, the bar graph shows the different surgical techniques used for lip reconstruction. The most common technique was the anatomical subunit repair. This paper is currently under peer review, but it is freely available for you to look at if you are interested on the preprint server medRxives. My second research question was completely different. This time I was looking at the cause of cleft lip and palate, and I was particularly interested in cigarette smoking to see if there was evidence that this was a causal risk factor. There have been suggestions in the literature in the past that there's an association between cigarette smoking and cleft. But the Cleft Collective is in a unique position because it holds different types of data, such as questionnaire and biological data, which enables a deeper investigation into causality. So first I looked at questionnaire data. This was filled in by mothers and fathers of children with cleft. And I was able to plot the proportion of mothers who smoked during pregnancy in the Cleft Collective. And this is shown by this solid black line going up and down in this graph. I was able to compare that against national trends of pregnant females who smoke in England and Scotland to assess the differences and similarities between the Cleft Collective cohort. And I will now move on to use biological and genetic data to further define the association between smoking and cleft, using a technique called Mendelian Randomization. And this uses genetic information to mimic the role of environmental factors such as cigarette smoking. The Mendelian Randomization will use smoking genetic instruments to be able to investigate the causal link between smoking and cleft. So as a trainee surgeon at the beginning of my cleft career, I'm full of ideas and I have lots of questions that I'm keen to find answers for. The array of rich data within the Cleft Collective provides a fantastic opportunity for people like me to try and find answers to these questions. And I've been very grateful for the support that I've received from the expert research staff within the Cleft Collective. And I hope that going forward that they're able to offer this type of support and data for researchers in countries all around the world, so that other important questions can be answered in this field of cleft. Thank you very much for listening.
Thanks, Matt. So that brings us to the end of our presentation. We do just want to acknowledge all of the people that are involved. This is very, very much a team effort. And so all of the other members of the Cleft Collective, as well as the NHS UK Cleft teams and our study participants and our partners, particularly CLAPA, the Cleft Lip and Palate Association, but also our funders, and with a particular mention to the Scar-Free Foundation, who had the foresight to fund the startup of this and really get it off the ground. So thank you very much for listening.
Thank you very much, Yvonne, Matt, the whole Cleft Collective. This was a super, Kerry. Thank you so much. We've had a huge turnout from all around the world this morning. And I think that's a testament to the fact that we really do recognize how important research can be in adjusting our practice and also understanding better what actually is happening on the ground. So take a second, please, wherever you are, formulate some thoughts. If you have a comment you'd like to say, you feel free to light up your video and you can ask that directly. Otherwise, I can read it for you if you put it into the chat. But I think there's lots to think about here in terms of this resource that's there. And we saw Kerry helpfully responding earlier that if you want to know more about the Cleft Collective, you can see in the chat, there is the website and an email address if you want to know specifically some questions about the data set. And I think I was particularly moved by, right in your mandate is the idea of working with people to sort of help establish what those research parameters are. And from the beginning, starting to think about how what you've learned from this huge process can be helpful to folks in other places who might be starting the same piece. While we're waiting for some questions to start, tell me more. I was really moved, I think, by those first three questions about the aims and how they really resonated with what I've heard from our partners in terms of what parents have wherever you are, in Africa, Asia, South America, wherever it is. Those three questions. Can you speak a little bit more about how you came to those three aims and how that's guided the data set that you've actually created? Yeah, certainly. I'm sure Kerry will jump in at times if, with other thoughts. I mean, the Cleft Collective is not something it's certainly not something that's come out overnight, but it's also not something that's even, we've been running for nearly 10 years, but there was much work that was done before then. The first discussions about setting up a study like this was back in 2006, a long time before I was involved, or Kerry or Matt for that matter. And some work was carried out with what in the UK is called the James Lind Alliance, and it's
a group who work with clinicians and with patient groups to establish what the priorities for research should be. And that's across a whole range of different client groups. And so that work was carried out for the population of children and families affected by cleft. And they're supposed to come up with 10 top priority questions. They couldn't come up with 10, they came up with 12. But in essence, when you group those, the questions were about, why has my child got this? What is the cause? Why is it me and my family? And then the next question is around, what can we do? What can we do? What's going to make a difference? How can we give my child the best opportunities possible? So the questions that formulated that were things like how old should they be when they have speech and language therapy? What should education do differently? How can we maximize well-being and ensure that these children are okay? And then the other questions that parents want to know, I think all parents want to know this, and this is particular to cleft, is you want to know, is my child going to be okay when they reach adulthood? So, as you say, Hugh, they are the questions that parents want to ask. It is what we see clinically with all sorts of different client groups. But this is also founded on some quite robust work that was carried out with clinicians and families and individuals affected by cleft as well to come up with those. Kerry, is there anything you wanted to add in there, or does that kind of cover it?
No, I think that covers it.
Okay, thanks.
Lovely. We have a question from Malawi from Nathan. So if someone wants to interact with your data, what is the can you recap a little bit about that process?
Yeah, of course. Of course. So, yeah, no worries. All the information you need is on our website. So if you just Google Cleft Collective, you'll find it. But like I said, we are here to support you carry out research. That's part of what we do. So if that all seems a bit daunting, then you can email me or the Cleft Collective email, which you can find. I've put it in the chat, but you can also find on our website. And just get in touch with us, and we can set up a call, a virtual meeting to discuss any thoughts that you have. Don't feel like you have to come with us with it all ready made. We can support you with that. We can talk through the data that we hold, talk about some ideas that you may have, and help you understand what you would want to get out of the research. And then once we've done that, then we ask you to fill in a very simple short research proposal form, so that we have it logged and we understand what you want to do. But again, we can help you with that. So really, the first instance, if you're interested, get in touch with us and we can discuss it further.
Thank you, Kerry. And just with my NGO hat on, also, Nathan, I know you're associated with Operation Smile. As you saw, Operation Smile, Smile Train, Cleft Charity UK, Transforming Faces, some of the NGOs on this call also would be interested, I'm sure, if you have an idea like that. Obviously, Kerry, Yvonne are very well positioned to help, but I think letting some of your sponsors know that you're thinking about these things can be helpful to help us understand how we can be supportive as well. Brian Summerlad, who we know has a lot of experience in helping to refine research, asks, what stands out for you as a key finding? What's getting you excited? And it might be 3 different answers if we think about Matt, Yvonne, and Kerry. But quickly, what stood out for you in terms of this research and the meaning you're making from it?
Yeah, I think that's a really good question. Kerry, do you want me to go first with this? Yeah. Okay. So I would pick out 2 main things, actually, Brian. One which is very much biological and one which is very much clinical. Quite early on, one of the pieces of work that one of our geneticists carried out was to look at the, I'm going to get my language wrong here because I'm not a biologist, but the methylation, the methylation
DNA methylation profiles.
Thank you, Kerry. See, it's teamwork here. The DNA methylation profiles for the different cleft types. And we, in a lot of research we've done in the past, we put the cleft types together. And certainly that was the plan with the Cleft Collective. Originally, we thought, we need, 3,500 children born with cleft, and that's our sample to be able to carry out the work we need to do. But what she found was that there were different DNA methylation profiles for children born with cleft lip only, children born with cleft palate only, and children born with cleft lip and palate. So that's without going down to UCLP and BCLP. Now, what that means is that the process by which those children end up with the clefts is different. It may be different genes, it might be a different environmental process, but we know that the process, the causal pathway for those 3 broad cleft types is different. And therefore the research and analysis that we need to do to understand the causes for those 3 cleft types need to be done with them as discrete samples. We can't put them together. Now, we already know from a clinical outcome point of view that those children have different kinds of outcomes. So there's a need to look at them differently, but now we know that when we're looking at causes, we also need to look at them differently. So that would be one thing. Another thing, another paper that's only just come out and shows what some of the potential for this work. Some work done by Stephanie Van Eden, who's a speech and language therapist up in Newcastle in the UK. And she used the data to look at the reports from parents of early communication behaviours. So this is children at around age 1. They're actually 13 months when we ask parents to complete this questionnaire. And we're asking them to talk about broad communication skills. Do they turn when their name is called? Do they respond when they hear sound? Do they are they starting to produce sounds that are starting to sound like words? Do they put their arms up to be picked up? These very broad communication behaviors. So we're not talking about speech per se, but we are talking about the thing that precedes speech, the desire to communicate. Now, what she found was that the children in the sample, she was particularly looking at comparison between children with Robin sequence and children with cleft palate but without Robin sequence. But actually what she found was that across the board, the group of children with cleft palate were performing lower than a control population. So even before we start talking about speech, our population are showing a slight delay in the development of their early communication skills. Now that could be part of the reason why it could have a knock-on effect on their speech development, but it could be part of the reason why then when they get to school, they struggle more. It's that knock-on effect. So we now know, okay, get in early, not just to focus on speech and babble, but to focus on promoting communication behaviors early on, because we know that these children are, as a group, behind their peers. So that's 2 very different examples. Brian, there are lots more, and I could talk for a long time, as Kerry will tell you. So I won't say any more. I don't know again if Kerry or Matt want to add anything there, but I'm sure that there's other comments coming through. So.
Oh, only just quickly to add that we put all our papers up on our website. So if you wanted to see how others have used our data, have a look on our website, and we list all the papers, and the links to the papers are on there as well.
Fantastic, thank you. Suraj, in Chennai.
Yeah, thanks you. Oh, wonderful work by your entire team. I'm so, there's so many of ideas now. I have 3 quick questions, to the team. So the first question which I would like to ask is, the idea is global, asking from the perspective of, if I would like to join, if I would like to get involved. Though it is collective, the cleft as such is so heterogeneous group. So when you analyze the data, will you look into some more regional specific information, or how this full data will be studied is is a question which I would like to ask. And another thing is, second question is, are you looking at like a mixed method? It's more of quantitative. Are you also looking at a qualitative research, like semi-structured interviews with parents, caregivers, families, maybe the service providers or something like that, to get an? Is there a mixed method research which is a part of this? And then third question, do you use tools like RedCap or something like that to collect data from international organization or partners? Yeah, thank you.
Kerry, do you want to go first with some of that?
Yeah, 3 questions for the price of 1, Suraj. All right, fine. Go ahead.
And then I'll pick up the thing. If you pick up what you want to answer, and then I'll pick up other bits. Is that okay, Kerry, or do you want me to start?
So I'll start. You jump in.
Okay,
so
fine.
with the first question, the regional, yeah, that is something that we could look at, yes. And actually what we were able to do during COVID is when we very quickly put together our COVID questionnaire, and we sent it out to parents, and from the results we were able to separate them into different reports for each of our regional cleft teams on how the parents and children were affected, and we were able to send just regional reports to each of the cleft teams for them to update their practices in light of what was working and maybe what wasn't working as well. So we have actually used that in practice, but in terms of the actual data, yes, that is something that we could do, because we've got 16 sites. We've obviously got a lot of participants at various sites. I don't know, Yvonne, did you want to add anything more about the regional question?
No, I think that's it. I think, yeah, we have got that data, and yes, we can look at how it varies across the country, and that's one of the key things that we would be doing. Yeah.
I'm going to leave the second question to Yvonne, but just on the REDCap question, yes, we do use REDCap. We do use that for sub-studies. Yvonne mentioned Stephanie Van Edem's research. We've used REDCap for that research. But we use with our questionnaires, we use a software which scans all our questionnaires in as well. That's called Formic, so we've used that as part of the questionnaires. But REDCap, yes, absolutely.
So just to pick up on the middle question, which was about the research methodology, it's a very good question, Suraj. The main data set is a large quantitative data set with large sample sizes. However, there is the potential to do sub-studies, and that can include some qualitative work. We have had some qualitative work going on alongside the work that we do, which is kind of stood slightly separately. So we've had some work carried out with focus groups with adults born with cleft to understand more about the issues affecting them. So along the way,
and with health professionals as well.
And with health professionals, yeah.
We've done that as well. Yeah, talking to the health professionals about the recruitment process and all of that, and the with the well-being questions as well. We've done some qualitative work using that, talking to parents. Yeah.
And in fact, one of the things that we wanted to do was to carry out interviews with parents following the first COVID lockdown that we had in the UK, to understand how that's impacted them a bit more. So that, there is the potential to do some of that qualitative work as well. And wherever we can, we just make the data available to people. So yeah, okay.
Thank you. Thanks, Suraj. Just a quick speech therapy question. I know that we've got Professor Tim Westby from the University of Toronto. Leaning in a little bit to your timeline document and thinking about the recordings. So the question was, are you keeping acoustic recordings from 24 and 36 months also?
Yeah, Tim, that is a really good question. And I would love it if we could, but no, we don't keep those. So what we have is we've got recordings at 13 months from Lena. At 2 and 3, we have got the speech and language therapy assessment form. So that's, and they're not based on recordings always. So so we aren't collecting recordings from those. At age 5 in the UK, all of the children are recorded. They then have, Tim, I think will be familiar with this as others here, that they have the CAPS-A scoring of those recordings. So although we don't collect the recordings, the data from CAPS-A will be available when the children reach age 5. And the recordings are still there. We don't have them, but the potential for building in research where people go back to listen to them, all of these things at the end of the day, to some extent, come down to money. So we're not collecting and collating those. There's storage issues with that, as well as as well as the difficulty in getting them. I hope that answers it, Tim, but feel free to follow up separately.
And thanks, Tim. Thanks, Yvonne. Quick question, as our time is starting to run down, one thing that really caught my attention, often in working with partners, or at least, obviously, as you mentioned, you might not be in a position just inside their hospital infrastructure or the university infrastructure to start to do the exact same thing you've done, but want to move towards an evidence-informed approach. And the idea of using the same kind of templates that you're using, for example, for speech therapy, for assessing, Can you say more about that and the accessibility of that? I mean, it's very interesting, the idea that, oh, well, the Cleft Collectives have used this for, thousands of surveys. At least if we can get a hand of some of those questions, we can start moving in that direction. Can you say more about that?
Yeah. So in terms of, it's easy enough to share the forms. That's not a problem at all. But from my conversations with colleagues around the world, just having the forms it doesn't necessarily work with how the service is being delivered there. I mean, we do also have a survey of intervention provided. And again, that's something we can share with people. But it's about how it fits with your local service delivery. And that varies hugely across the world, particularly for something like speech and language therapy. There are many countries where speech and language therapy doesn't even exist as a profession. So it is a challenge. That's why I don't want to sort of pretend that it's not. This is not, in many situations, you're not going to be able to just take this and copy it where you are. It's got to be how it fits with how local services are delivered. I think there's a huge amount of work as well that has to be done before you get to this point of building relationships, developing a collaborative approach to clinical care, and then using that as a precursor into a collaborative approach with research. In the UK, for many, many years, since 2000, since centralization of services, the services across the UK have worked very closely together, and they have worked very hard to agree what they collect, certainly at age 5. Even for us, it was a new thing to go down to age 3 and age 2 and agree what we collect. All the services were doing something slightly different, and that's in an environment where people are used to working very closely together. So I don't have any easy answers to that. We can give you what we collect, and we would be very interested to talk with people about how they might implement it in their local environment, because what we would want to understand is, okay, you've collected this, but for example, maybe you don't have speech and language therapists in your country, and actually it's a nurse that collects this who hasn't got phonetics training. It's not about not doing it, but it's about us understanding how it might be different. Or it might be that speech and language therapists see children at all sorts of different times, and they can't possibly say, I'm going to definitely see them at age 2 and 3. You see them when you can get them. So, we have to acknowledge the differences across the world in that. We'd be keen to work with people to understand those and problem solve with people. I hope that answers that, Hugh.
Yeah, that's a good start. Thank you very much. And I think just along that line, Niti, as we sort of transition into the end of our hour, I guess this will be the first time officially that I'm going to announce on behalf of the Circle of Cleft Professionals that we will be sponsoring an award called the COCP Award, and it's for comprehensive cleft care research that's rooted in LMIC contexts, that really has the potential of pushing forward what kinds of things we're talking about. And built into that is the idea of that north-south or south-south, collaboration, the idea of working together potentially with people who have more experience in publishing and dealing with this kind of data set, along with people who are really hungry and keen to learn more about how this research could move forward in their own context. So that is something that will be announced at the Edinburgh conference, and we're really excited by that. Some of the collaborative nature that we're hearing today from the Cleft Collective and also obviously from colleagues around the world. I see Alan Oslander is on the call today, and that was one of our first research-focused COCP webinars talking about the influence of things like cooking over an open fire, and that was something that really caught my attention, something I hadn't read before. And then the idea of comparing data sets between things that are collected in the global north into specifically the experience of people living in low and middle income country contexts and how that influences cleft care. Niti, if we could jump into our final slide, just as the hour going, it's been a great turnout this morning, some great questions. My question for everyone on the call, and I think Yvonne has started to think about this a little bit more and get us ready for this. What's an idea from the discussion that's most compelling for you? Are there some people on your own team, wherever you are, that you'd like to talk about looking at the Cleft Collective research, the data set, how that's driving some of the questions that you're facing every day about how to make effective comprehensive cleft care move forward, even potentially, as Yvonne mentioned, in a context where there are very few or no speech therapists, for example, and what's some of your next step? It's more of a rhetorical question at this point, but think about that. And that's something we'd love you to hear more about. If you want to send us an email, info@cleftcircle.org. We'd love to hear what you're thinking about. And we're really excited about 2 more webinars coming to get us up to number 30. The first is, not only is there a shift in terms of how research is being approached in low and middle income countries, there's also a shift towards how especially surgery is being approached. And so we've got Dr. Jordan Swanson with a lot of experience with an emission model, talking within his new textbook, which I think is very helpful. We'll hear more about that shift that's coming. He's got a partner named Nicholas Sierra, who's very well known in Mexico, and a Smile Train partner who will also be joining him. This is going to be a really interesting discussion. So it's coming up soon, December 8th. Don't miss it. And then looking forward to the new year, we heard Marina in the chat earlier and some of the research she's involved with. But we've also got Dr. Omolao Orunuga from the president of the Nigerian Association of Pediatric Dentistry, who will be presenting a little bit more on oral health. So varied topics coming. Don't miss it. Plan your calendars. And we'll look forward to seeing many of you next week, basically on December 8th. You can find some of the recordings already. Maybe Alan Oslander's presentation. Look back on what happened today. That's on the Circle of Cleft Professionals YouTube channel. We're on Twitter, and you can send us an email at any time. A huge thanks to our team from Yvonne, Kerry, and Matt. Thank you for that preparation. I think it was a great highlight of the resources out there, and we look forward to seeing you all again soon. Thank you.